Good day, e-learners. Welcome to Access California's e-learning module about the public mental health system. Today we will before we jump into the materials. Access California, or Access, is a program of NorCal MHA, Mental Health America of Northern California. We are a consumer-led stakeholder advocacy program funded by the California Mental Health Services Act, or the MHSA, or Prop 63 in 2004, and the Mental Health Services Oversight and Accountability Commission. Mental Health America of Northern California, or NorCal MHA, was founded in 1946 and is the oldest continuously operated consumer advocacy agency in California. NorCal MHA is a peer-run organization that specifically hires people with lived experience. So, ACCESS is an acronym. It stands for Advancing Client and Community Empowerment Through Sustainable Solutions. At ACCESS, we value advocacy, recovery, and peer support. Now let's spend some time talking about what that means. In terms of advocacy, we are striving for meaningful stakeholder participation, active solicitation of community feedback, expanded opportunities for stakeholder involvement, and stakeholder inclusion at all levels, which includes policy development, program planning and implementation, and service delivery, oversight, and administration at the local and state level. With recovery, we're seeking the infusion of recovery-oriented principles in all aspects of service delivery, which includes client voice and choice, individualized services, shared power in decision-making, and treatment always being voluntary. We advocate for recovery-based training and support for mental health professionals, as well as tracking, reporting, and analysis of recovery outcomes in all mental health fields. Finally, when we talk about peer support, ACCESS is advocating for fidelity to the evidence-based model of what peer support really is, and incorporating an expansion of peer support in all mental health programs. We advocate for living wages, ongoing professional development, and opportunities for advancement in peer support positions. What you see here is what ACCESS actually does. We do research, we do advocacy, we do education, and engagement. Those are all rooted in the three values that we started with before. Okay, now we get into the meat of the program. The e-learning module today is about California's public mental health system. We are going to frame today's discussion about what the public mental health system is, how it works, who's eligible, and how to access services. All right, let's begin. We're going to start with part one about what the public mental health system is. For today's discussion, we're going to use the definition of the public mental health system as expressed in the California Code of Regulations. The public mental health system means publicly funded mental health programs and services and entities that are administered in whole or in part by the county or California's Department of Healthcare Services. Okay, if we look at it in a visual term, you can see that there are three layers to the public mental health organization. There's the state agencies that include the further oversight and administrative duties to make sure that the funding is available and well administered. In the middle, you'll see 59 local mental health agencies. That includes 56 independent counties, 2 joint power authorities, and 1 city organization that allows for them to distribute and create local mental health systems for their regional spaces. And then, as well as how it's administered through the community-based organizations that are for the end user, like you and I. We also want to be explicitly clear about what the public mental health system is not. It does not include programs and/or services administered in whole or in part by federal, state, county, or private correctional entities, programs or services provided in correctional facilities. This includes state hospitals as well as state jails and prisons. All right, let's talk about the public mental health system requirements. First, we have to look at income, and second, we have to look at medical necessity. In terms of income, people with low income or no income and that have Medi-Cal insurance or no insurance are available to access the public mental health system. We also have to look at medical necessity requirements. A client or consumer or person using the public mental health system has to have a diagnosable mental illness, as well as a difficulty functioning in an important area of life function or the probability of significant deterioration in an important area of life. This could be including a job or school or living arrangements or elements that allow for independent lifestyle. The expectation is that the proposed treatment will significantly reduce the problem or prevent significant deterioration in an important area of life functioning. This requires a condition that would be non-responsive to physical health care-based treatment. Now let's take a moment and consider the income threshold for Medi-Cal coverage as well as the public mental health system. We were looking at 200% of the federal poverty limit. Right now, in 2019, an individual making $12 an hour minimum wage and earning approximately $24,280 a year would qualify. You'll also note that in the diagram, you'll see a variation of what programs are covered and what the thresholds are. So for public mental health system, it's 200% in comparison to those that go higher for prenatal care, newborns and infants, and children on the greater part of it. When we start to analyze the public mental health system priorities, it comes down to adults with serious mental illness that meet the following criteria. It must be severe, it must be persistent, and interfere substantially with primary activities of daily life. It may also result in an inability to maintain independent functioning without treatment, support, and rehabilitation for long or indefinite periods of time. Similarly, for children and adolescents with serious emotional disturbance, it must have an identifiable mental disorder that results in age-inappropriate behavior and are substantially impaired in at least 2 areas among self-care, school functioning, family relationships, ability to function in the community, and are also at risk of removal from the home or have already been removed. What we must also keep in mind is that the public mental health system is targeted towards low-income groups and has priorities within these groups that vary county by county. Each county sets its own goals because of local control public mental health system operated by county agencies or local mental health agencies. Now we'll move on to our second question, how the public mental health system works. So let's look at all the funding sources first. In this diagram, you'll see the breakdown of California County behavioral health funding. You can see that it's primarily Medicaid matching funds, as well as about 25%, 22% Mental Health Services Act dollars, another 33% of realignment, depending on if it's from 1991 or 2011. And then there's about 4 other elements that make up the round total of the behavioral health system that costs about $8 billion in total funds in California. First, we'll start with how the funding stream comes from the top all the way down to the end user. The largest percent of the funding that California receives for public mental health care is from the United States federal government program of Medicaid. In California, it's known as Medi-Cal. Medi-Cal reimburses the states and counties for services provided to Medi-Cal beneficiaries. Again, those with little to no income. California's federal Medicaid assistance percentage is about 50% for most expenditures, and it requires a legal obligation to pay for all medically necessary covered services for eligible individuals. An additional federal spending that you might recognize from the previous slide was the SAMHSA block grant. It comprises a small percentage of the total funds for the public mental health system, but it offers a flexible funding source for adults and children services ineligible for Medi-Cal and those with no health care coverage. So beyond the national funds, we come down to California state funding. California pays for public mental health services primarily through dedicated revenue sources, and it flows directly to counties. This comes from the realignment of 1991 as well as 2011 that dedicates sales tax and vehicle license fees directly to the 58 counties, and then additional money that comes from a 1% tax on annual income over $1 million is from the Mental Health Services Act. The primary use of general funds in the California public mental health system is to provide assistance with prescription drugs, and in addition to providing school-based mental health services and a little bit in the criminal justice services. Now we're down to the county level. If we look at county funding, you're going to find revenue from local property taxes, patient fees, and some payments from private insurance companies. The county general funds account for a small percentage of total funding of the public mental health system. However, part of the county funding goes toward county maintenance of effort, level spending, and the amount required to receive their portion of state sales tax revenue. Remaining money reserved for mental health services is mostly discretionary and varies year to year. All right, we started with the financial analysis, and now we're going to start with how the organizations are broken down in that pyramid we started with at the beginning. We'll start with the state level decision making. That runs through the MHS-OAC, the Department of Healthcare Services, OSHPD, and CalMesa. There's committee meetings as well as Behavioral Health Planning Council that allow for stakeholder input and involvement. When I say DHCS, I'm referring to the Department of Healthcare Services. In general, they oversee the whole Medi-Cal healthcare program. That operates at about a $93 billion budget. And mental health, which we're concerned about in the public mental health system, is about 3%, and those are the federally matched dollars from Medicaid. What DHCS is required to do is contract with local mental health plans to provide services at the county level. They are also required to collaborate with the Planning Council and the Commission on Oversight and Accountability on the delivery of MHSA services and other non-Medi-Cal community mental health plans. To include family members and consumers along in the process, DHCS is required to work with the California Behavioral Health Planning Council. It is a majority of consumer and family members and serves as an advisory body to the state and local government, as well as the legislature and residents of California on the mental health services in California. Their duty is to inform the administration and the legislature on priority issues through publications and reports, as well as provide feedback on mental health policy and regulations. A Behavioral Health Planning Council is required by SAMHSA in order to receive block grants funds from the federal government, in addition to a best practice to ensure mental health policy is client-driven in California. A collaborative partner to DHCS is also the Mental Health Services Oversight and Accountability Commission. They oversee the implementation of the Mental Health Services Act, in addition to advising the governor and the legislature on California mental health policy. The MHSOAC includes the commission meetings, 2 committee meetings, as well as holds community forums across the state. Again, I want to reiterate that the public mental health system does not include programs and services administered in whole or in part by federal, state, county, or private correctional entities, or programs or services provided in correctional facilities. In terms of state hospitals, there is a federal exclusion for institutions of mental disease. So counties pay 100% of the cost for civil patients between the ages of 22 and 64. Currently, as of 2014, there were only about 200 patients in total. The primary population of state hospitals is forensic patients and is the responsibilities of California's Department of Correction and Rehabilitation. Breaking down from the pyramid, we're going into the county level of management of mental health care. Counties are responsible for administering nearly 90% of public mental health services in California. County boards of supervisors are required by law to oversee these local mental health programs, with input from the local mental health advisory board. To provide these mental health care systems, counties are required to have 2 contracts with DHCS detailing how they provide mental health services in accordance with the Welfare and Institutions Code. This includes the Medi-Cal Mental Health Managed Care Contract that includes coverage and services under the 1915B waiver program, as well as mental health performance contracts that include the non-Medi-Cal mental health services. When we start to talk about California public mental health system, we have to recognize we are a large state. There are 59 local mental health agencies. This includes 56 independent counties, 2 joint power authorities that are Sutter-Yuba Mental Health Agency, as well as the Tri-Cities Mental Health Services, in addition to the one city of Berkeley that operates independently from the Bay Area. As an advocacy organization, we wanted to provide this slide as a resource for the seminal mental health legislation that has passed in the last 50 years approximately. These 5 different acts have outlined how the public mental health system operates today. Okay, we are on part 3. We've gone over what it is, how it works, and now we need to know who it applies to. Who is eligible for the public mental health system? When we talk about eligibility for the public mental health system, access depends on age, insurance status, illness severity, as well as the county of residence. The criteria for receiving outpatient Medi-Cal specialty mental health services includes a diagnosis, an extreme impairment, and that intervention may improve conditions. Earlier I mentioned the 1915B waiver program. This is an expansion of Medi-Cal services that is now operable for specialty mental health services for adults that are 21 years or older experiencing serious mental illness. It ensures that they can find services or maintain stability with the things that are listed below in order to find treatment through Medi-Cal. In the previous slide, you may have noticed the cutoff of 21 years of age. This is because children and young adults under than 21 are qualified for Medi-Cal under the EPSDT program. That's early, periodic, screening, diagnostic treatment. Consistent with state and federal law regulations for EPSDT, Medi-Cal covers all medically necessary services, including those to correct or ameliorate defect or physical and mental illness or conditions of beneficiaries under age 21. We're talking about California's public mental health system. California is a large state. There are 58 different counties and 59 local mental health agencies. The local controlled county system means that there is a great variation between the successes and failures across the state. It varies county by county in the consideration of average spending per enrollee or community penetration rates. California is split into regional districts to compare similar counties, and the bar graph illustrates the above average rates of SMI and SED in the Inland Empire, Northern and Sierra regions, and San Joaquin Valley. These are also known as more rural and poorer regions of California. We are just about to wrap up with part 4 of how to access services. The best way to access the public mental health system in California is through the County Management of Mental Health Care. Counties are responsible and administer nearly 90% of public mental health services funding in California. Through that, they operate crisis centers, peer-run organizations, community services, as well as partnering with jails for discharge services. So when you're looking for services, contact your county administrative or county behavioral health agency, and you'll find access to any of these organizations or programs to get services. All right, today we covered California's public mental health system. We talked about what it was, what it is, how it works, who's eligible, and how to access services. We also want to provide some online resources to contact your local mental health agency. Access California provides statewide resources that include a full directory, our regional mental health advocacy ambassadors that encourage client-driven policy in local, regional, and statewide mental health policy. We provide e-learnings, education, training, webinars, and various opportunities to get involved and engage and learn more, in addition to our mental health policy papers and overview of local legislation that may be happening at the moment. NorCal MHA also provides services for Sacramento, Placer, and Amador County through the county contracts. At the bottom are more mental health service organizations' statewide directories for things you may be looking specifically for. As an advocacy organization, Access also offers a stakeholder ombudsman and advocacy helpline. Stakeholders can report barriers to participation and perceived violations of the community planning process, as well as Access will review the complaint, conduct research, and will initiate a resolution with the local and state mental health agencies in question. Additionally, callers can receive help navigating our online, local, and statewide advocacy directories and assistance advocating for mental health needs in the local grassroots level. To reach the Stakeholder Ombudsman and Advocacy Helpline, call 707-572-4357. An easy way to remember this number is 707-572-HELP, H-E-L-P. Thank you for attending this presentation. Please reach out to us anytime over the web, by email, phone, or social media. Have a good day.